Fight bite. So whenever I will see a patient of a fight bite injury in A&E, I will need to assess regarding a pertinent history, examination, and a radiological investigations. If it's a acute fight bite and no stigmata of infection itself, I will still have a high threshold for a debridement and admission of the patient. The reason being that fight bite can have cause of bacterial infection and inoculation of bacteria into the joint of metacarpophalangeal joint. I will assess the patient A&E, check for the tendon, for the movements of the fingers and range of motion, and exclude the tendon injury itself. Anyhow, I will admit the patient, start proper antibiotics, and review the patient and for operative intervention. Regarding my operative plan, I would take the patient to theater, expose the marked and consented patient with the WHO criteria being fulfilled. I will flex the fingers, and in a position of making a fist, I will extend the incision proximally and distally, expose the area, and then after assess the tendon, debride the joint, and wash out, and then repair the tendon if there is no signs of infection itself. The positioning inflection is because the infection happens because when the injury with the fight bite happens, the fingers are in flexion, and later on with extension, the bacteria get entrapped inside the joint. Regarding the tendon repair, it depends on the area of the location of the tendon injury, but I would prefer, if the tendon is bulky, I would prefer to do a 4-strand repair, if not 6-strand, which consists of Kessler or Adelaide repair. I will splint the patient with a back slap. I plan to assess him to continue with the back slap for 4 weeks. I will do if the tendon is repaired optimally, I start doing active Belfast regimen. The problems which can happen is infection, needing further debridement, and tendon adhesions which needs tenolysis.